everybody, and welcome to today's webinar brought to you by the Orthopaedic Research and Education Foundation India through OrthoTV. Today we have the pleasure of having Dr. Ramesh Perumal from Ganga Hospital, Coimbatore. I think Ramesh, I've known him for many years. I think I've seen him from the time he was a resident, and now he's one of the people who's done the most acetabular and pelvic fractures in the world. So it'll be really interesting to listen to him. And he's going to tell us about the diagnostics in acetabular fracture. So the radiology and assessment of acetabular fractures. And I'm sure all of you should find this interesting. And we look forward to this talk by him. So over to you, Ramesh. Thank you.
So thank you, sir. Thank you very much for your kind words. First of all, you're also my teacher. I learned a lot from him. The first illegal approach in 13 years back, I learned from you.
Okay.
So I still remember the events. So I start sharing my presentations.
Sure.
So good evening to all of you. Today's lecture will be focused on the radiology and classification of acetabular fractures. So as you all know, these are all high-end spectrum of injuries, so which needs to be classified because to make a plan of treatment options, so the classification and documentations are very, very important. Of course, all the classifications of orthopedic starts from X-ray. So further, the radiology been further moved on to the CT scan and other investigations. However, most of the acetabular fractures can be diagnosed with the brain radiograph alone and also with special use of Judets. Today, we mainly, before reading on radiography, it is very important to focus on the pelvic osteology, the osteology of acetabulum, and certain defined radiographic landmarks on the X-rays, and then we can move on to understanding the classification of acetabular fractures. So as you all see, the pelvic model, so you can see the acetabulum has got the anterior wall, the anterior column, and posterior wall and posterior column. It is very, very essential to spend a good time with a bone model, and then you can see all the landmarks by your vision. Then you can just look into the radiology. This pelvic model, I was very much inspired with the Robert Judet and Letournel's work on pelvic acetabular fractures. In the similar way, I also planted all the stainless steel wires over the walls of the acetabulum, the columns. So, and then you can take a Shyam picture and then you can define all your landmarks. It is very essential to spend a good time with the bone models. When you come to the anatomy, as you all see, it is acetabulum is like an inverted Y shape between two columns. So the anterior column and the posterior column both have joined in the supraacetabular region, and further the sciatic buttress will extend. So the two columns forms a Y-shaped construct. Then it is got linked with an sacroiliac joint along with the sciatic buttress. Sciatic buttress is one of the strongest part of the bone. Here the white color shadow represents the anterior column and the red color shadow represents the posterior column. So posterior column is the behind, it's got the very strong osteology. So now when coming on to the anterior wall and column, we can see the anterior column extends from the iliac crest, the anterior superior iliac spine. It extends down up to the anterior inferior iliac spine, then comes over the anterior wall, and then it is coming onto the pelvic brim up to the superior pubic rami. These are all the boundaries of an anterior column. However, between the anterior inferior iliac spine up to the root of the pubic rami forms the anterior wall. So you can see the middle diagram, which is the anterior wall, extends from the anterior inferior iliac spine to the root of the superior pubic rami. So the posterior column, you can see this extends from the greater and lesser sciatic notch. So it starts from the greater sciatic notch, it curves down along with the ischial spine, it goes up to the ischial tuberosity. So the ischial spine above is the greater sciatic notch and below is the lesser sciatic notch, and also the covering is called the posterior wall. So you could see the red color is the posterior column of the acetabulum. So as you all see, it is an acetabulum has got an anterior wall, anterior column, posterior wall, and a posterior column. So when it comes to the radiographic representation, commonly what we do is an anteroposterior view, and the other two special views are obturator oblique view and an iliac oblique view. And then further it has been expanded to CT scan, which may be a 2D or a 3D reconstruction films. Now we'll move on to one by one. As you all see the radiographic landmark in an AP view, we all tend to see some lines for the column and the wall and also the weight bearing dome. So these are all the landmarks which we see. When coming to the obturator view, it is the Robert Judet and Letournel has defined these views because it was defined in 1970. So at the time, the CT scan was not available. So what they have tried placing the copper wires in both the columns, and then they have taken a different views, and then this 45-degree of an oblique view where the injured side is lifted up, where the beam is perpendicular to the anterior column. So when you take an obturator view, you can see the full profile of the anterior column, that is an iliopectineal line. And also in the behind you can see the posterior wall. And then they lifted the uninjured side to 45 degrees. Then they found out it is perpendicular to the posterior column, where you can see the ilioischial line as a posterior column and also the anterior wall. So these are all the three landmarks which is very essential in reading the X-ray of an acetabular fracture to come out to a conclusion of a diagnosis. Here you can see the 45-degree oblique view. On the left hand side you can see the full profile of the iliopectineal line of the anterior column, that is an iliopubic column, and also the posterior lip of the acetabulum. So this view is very essential to see two findings: anterior column and a posterior wall. Other important finding is you can see the obturator ring as a complete profile. So you can see the involvement of the obturator ring. Sometimes the ring may be broken, that may be a part of a T-type fracture. If an intact ring, it may be a part of a transverse fracture. So we'll come to the classification little later. Then you come on to the iliac oblique, you can see the intactness of the posterior margin of the ilium along with the sciatic notch and also the anterior part of the acetabulum. So we can see all the disrupted lines in an X-ray so that we can come to the conclusion of a classification. Here you can see the bone model which I have been planted the stainless steel wires, and you can see the different anterior wall, anterior column, and the posterior wall and the posterior column. So when you take an anteroposterior view, first you have to make sure that whether the view is symmetrical or asymmetrical. So many times in a traumatic situations, pelvis X-ray may be asymmetrical because of positioning. But however, in many times when you see a symmetrical view, our findings are very corroborative with our evidence. So first thing is then if you take a right side, first thing is the iliopectineal line. This is a line extends from the superior pubic rami, it goes along the pelvic brim and also extends upwards into the sciatic notch. That is an iliopectineal line, is an indicator of an anterior column. And second thing is an ilioischial line. This line starts from the inner border of the ischial tuberosity and vertically extends above into the posterior side, and also it goes in the greater sciatic notch. So ilioischial line is a measure of a posterior column. Then the other important thing is the radiographic tear drop, where it is the form the medial boundary of the acetabulum and also a part of a quadrilateral surface. Many times this will get injured in a medial acetabular or the quadrilateral plate injuries. And the other important finding is the roof of the acetabulum, where it is the weight bearing dome is affected or not. So these are all the findings you should see in a case of an acetabular fracture, a weight bearing dome is involved or not. And the other one is the anterior wall fracture. which is little bit because of a little bit of anteverted hip joint. The anterior wall is more certain, it is overlapped. It extends from the root of the inferior part of superior pubic, extends above like an oblique line extending into the outer lip of the acetabulum. And the posterior wall is more or less like the oblique line which extends from the lip along up to the outer border of the ischial tuberosity. So it is whenever you read an X-ray of an acetabular fracture, you make sure that all these 6 lines, wherever they interrupted, we can get a finding. So, and also important thing is you can see the Shenton's line to look for an dislocation or not. So make sure that the obturator ring is symmetrical and X-ray is centered properly in most of the cases. Here you can see the same with the bone model along with the Shyam picture in an obturator view. You can see the iliopectineal line and also the full profile of the posterior wall. And when the model is tilted inside like an iliac view where you can see the ilioischial line. So the ilioischial line, you can see it is going along the ischial tuberosity, curving along the ischial spine, going up the sciatic notch. However, in an AP
Okay,
view, in an AP view, it likes like
अभी आपकी एरिया एक्चुअली मीटिंग में 8:30 तक ऑनलाइन.
Your sound is coming just.
so when I taken the ilioischial line, it appears as a curved line, but when it's taken APV, it appears like an more or less like a straight line because of the obliquity. And when you take the anterior and posterior wall boundaries, you can see the anterior wall is very much anteverted, and you see in the bone model and also in the Siam picture of the model, and also in a posterior wall, you can see it is more or less like a vertical view and an obturator view. So these are all the boundaries of the anterior and posterior wall. So this is the part of the posterior wall where you can see it extends from the anterior side, it goes along up to the ischial tuberosity. So this is the teardrop and also the radiological roof. So the radiology roof is the measure of the weight bearing dome of the acetabulum, and also you can see the teardrop is the middle part of the acetabular wall. And just above the iliopectineal eminence is one of the very strongest part of the acetabulum part, where you can have the anterior column screws can be held onto the iliopectineal eminence. So these are all to summarize the findings, where in an obturator view where you can see the pelvic brim and the posterior brim, you can see the obturator foramen and also the radiological roof. So in oblique view, obturator oblique view, we get the 4 findings, and then anterior column and the posterior wall, radiological roof, and intactness of the obturator ring. The similar way in iliac view, we can get 3 findings. One thing is the ilioischial line and an anterior rim, and also profile of the iliac wing. Sometimes the fracture line might be extending up to the ilium, so the profile of the fracture pattern of the iliac wing also seen in an iliac view. So these are 3 findings which you can get in an iliac oblique view. So computer tomography has real revolutionized the acetabular fracture management, because certain findings are very much obvious in a CT scan, whereas it is doubtful in an X-ray. The other thing is the joint congruency and presence of an intra-articular loose fragments, and also the number of fragments in either the anterior or posterior wall, particularly the posterior wall, the number and fragment size is very much appreciable in an CT scan, and also the associated femoral fractures sometimes missed in an X-ray. And also the most important finding in posterior wall in 25 to 30% of the patients are the presence of a marginal impaction. So this warrants an important in the clinical outcome and also the intraoperative decision making by replacing the impacted fragment and also filling the defect with an bone graft. Either it may be from the trochanter or it may be from the iliac crest, or you can get it from our bone bank. So, and also the other important things which have revolutionized is that 3D reconstruction and head subtractions. So 3D reconstructions used to give a real-time involvement of the all part of the column and the wall. It gives us a better understanding. And also the further on to this is the head subtraction, where you can see the subsac in the head. We can go into the acetabulum and then we can see the real-time morphology of the fracture pattern. These are all the advantages of doing the 3D CT scans along with the head subtractions. Now let me move on to the Letournel and Judet classification. This Letournel joined Robert Judet in 1965, and then all the Robert Judet's works have been compiled, and then Letournel has come out with this classification of acetabular fractures, and then all this have been described in their book. So the essence of the classification is an anatomically based classification. They have defined the complete morphology of the acetabulum in the form of an anterior wall, and also the anterior column, and the posterior wall, and the posterior column. So based on the involvement of the anatomical structures, so they have given the guide to approach this type of fractures. This is one of the easy classifications, can be used by all. So even though there are so many classifications have come about the acetabulum, still the gold standard classification, Letournel and Judet, there are column specific classification. All these sub classifications have come over a period of years, but still this classification was published in 1970. Still 50 years, this is one of the very gold standard classification for acetabular fractures. One of the important thing is this classification evolved before the CT was invented. So based on these landmarks, they have a lot of them are paper drawings and also bone model. These classifications were described, and also based on the classification, they were also divided the principles of fixation methods, and the anterior approach of the acetabulum was first extensively described by the ilioinguinal approach, were first described by Letournel and Judet based on the cadaveric study. This was published in 1972. So 50 years have been gone, and most one of the standard approach for an anterior based fractures are the ilioinguinal approach. However, the approaches like an anterior intrapelvic approach plus lateral window is commonly used. However, in certain situations, still if a ilioinguinal approach is better for the middle window, is one of the better for our fixation methods. So they have classified the acetabular fractures as two groups. So one is the elementary fractures and it's an associated fractures. When you take about the elementary fractures, only one component is involved, either an anterior wall or an anterior column, or a posterior wall or a posterior column. But they've included transverse fracture in elementary fracture because it is a two-part fracture. So it is running through from the anterior column up to the posterior column. But essentially the ring is intact. It is a kind of a two-part fracture. Hence they've included this transverse fracture and elementary fractures. The other thing is when the opposite column is involved, the term is an associated fractures. The commonest one what we commonly used to see is the posterior wall and column fractures, and also the transverse with posterior wall. So you can see the optic ring is intact, but when the optic ring is broken, it is a T-shaped fractures, but you can see the intact articular surface attached to the ilium. So when there is an anterior column with an posterior hemitransverse, there's also another type of an associated fractures. On the other, the classical one and the last one is a both column fractures, where both the columns have fractured, and then a part of there is a dissociation of the weight bearing axis, and from the axial skeleton is the both column fracture. This is one of the severe form of an acetabular fractures. So now we run through the examples of all these acetabular fractures. So here you can see in a 41-year-old male who had an hip dislocation and presence to an emergency department, where you can see some the dislocated hip and the small fragments near the posterior wall. But you can see both the lines are intact. As you see, the iliopectineal and ilioischial lines are intact. As you all see in the emergency department, what we commonly see is the close reduction is one of the commonest procedures what we do in emergency room. So this patient underwent a close reduction of the hip. The reduction was successful without a difficulty. Now when you look into the X-ray, the joint is looking congruent. But however, when you have a closer look, where you can see even though the joint is congruent, you can see some amount of shadow is seen at the level of posterolateral corner of the hip joint. So when you take the special views of the Judet, when you can see the operative view, where you can, as you previously mentioned, the iliopectineal line is intact, where you can see the posterior wall fracture with the fragment got lifted off. So it is best seen in an operative view. And iliac view is, of course, it is normal because the posterior column is intact and the anterior rim is also intact. So in a case of a posterior wall fractures, the major column lines are intact, but the posterior wall fragment is evident on an operative view. So when you go back to the previous, you can see the fragment is doubtful fragment on the posterolateral part of the hip. So when you take an operative view, the posterior wall is very well seen. So when you take the other view, other patient, where you can see the ilioischial line is broken. So you can see the iliopectineal line is intact, where you can see there is an protrusion of the acetabulum, and you can see the iliopectineal line is intact. However, you can see the ilioischial line is displaced inwards. So and the operator ring is also there's injured in the inferior part. There's a break in the ilioischial line is a measure of an posterior column fracture. So you can see the ilioischial line is broken. So when the other thing is when you come out to the anterior wall fractures, so sometimes the break in the iliopectineal part, the middle part is comprises the anterior wall fractures. The anterior wall fractures are commonly seen in elderly age group. So it is a part of an anterior column in between. The anterior column extends from the superior pubic rami up to the iliac crest. The anterior wall only between the anterior inferior iliac spine to the root of superior pubic rami. So it is a middle part of the anterior column. So it is also it is in a trapezoidal in shape, where it is mainly caused because of the impaction of the femoral head over the anterior and the medial part. The findings of an anterior wall fractures are many times the inward displacement of the femoral head, and also you can see a roof impaction, and also you can see the displacement of the middle part of the iliopectineal line. So here you can see the same patient, you take the Judet views, where you can see the lifted of an anterior wall fracture, the trapezoidal shape of the anterior wall, you can see it is getting lifted up, and also there is a roof impaction. In operative view, our other important finding are the integrity of the posterior wall. So the posterior wall congruity, the integrity is intact. However, the anterior wall is got lifted up along with the roof impaction. So when you take the Judet view of the iliac view, where sometimes you can see the point of rupture of the anterior column can also be seen, but however the ilioischial line will be intact because it is an uninjured site, and also some profile of extending into the ilium will also be seen in an iliac view. So when you come on to the anterior column fractures, so where you can see the break in the iliopectineal line. So the iliopectineal line can extend from the superior pubic rami also up to the iliac crest. Depending upon the level of exit, it may be a low anterior column or an intermediate or an high anterior column fractures. So depending upon the level of break, the anterior column has been divided. So here you can see the Judet views, as it has been mentioned earlier. We can see there is a break in the iliopectineal line in an operative view, where you can see the lifting up of the anterior column. In an AP view, we can see the break in the anterior column, but when you take an operative view, you can see the real-time lifting up of an anterior column, and also the integrity of the posterior wall, and also you can get the integrity of the operator ring. When the operator ring got broken, it may be another part of it may be an both column fracture, or it may be an anterior column with a posterior hemitransverse. Here in anterior column, you can see the fracture line extending into the ilium. In an I column fractures is very well seen in an iliac view. So now coming on to the other fractures, we have seen anterior wall, anterior column, posterior wall, and a posterior column. The fifth one is the transverse fractures. The transverse fractures is defined as a single fracture which extends from the anterior column onto the posterior column. Here it has been divided into two components. One is an the iliac component and also the ischiopubic component. Here one of the characteristic feature is the intactness of the obturator ring, where here you can see both the ilioischial line and iliopectineal line are broken at a single level with an intactness of an obturator ring. So here you can see the broken pelvic ring and a broken iliopectineal and ilioischial line at one level, an intact obturator ring. So when you take in a transverse fracture, the best orientation is seen in an obturator view, where you can see the exit of the column. So where you can see the femoral displacement. The femoral is getting displaced anteriorly. Our approach has to base on the anterior side. When it displaces more on the posterior side in iliac view, we have to go on the more on the posterior side. On obturator view, it is one of the clear indication about intactness of the obturator ring. And also in an iliac view, we can see the posterior exit of the transverse fracture. So depending upon the levels, you can see the level of fracture at the anterior column and the exit at the posterior column and intactness of the obturator ring. So these are all the characters which can be obtained in these special views. When you come on to the transverse fracture, there are a lot of subtypes are there. One thing is the transtectal, which goes through the weight-bearing dome. When juxtatectal, it is just the weight-bearing the root is intact. And infratectal is at the level of cotyledonate fossa. This carries an important in fixation strategy and the stability also. Transsectal fractures are more prone for an arthritis because it is going through the weight-bearing dome. So juxtacular also, depending upon, there will be a lot of rotation, so it needs to combine with a dual approach, or it can be approaching on only one approach. So now moving on to the associated fracture types. The first one is the posterior wall and column fractures, where here you can see the breakage of the ilioischial line. It is a measure of an posterior column, and also you can see the posterior wall fragments on the outer lip. So this is the APV itself, we can diagnose the posterior wall and column. When you go on to the other thing, the transverse with posterior wall, where you can see the ilioischial and iliopectineal line is broken at one level with an intact obturator ring is a measure of a transverse fracture. But in APV, we can see the triangular shadow above the joint line, which is a part of a posterior wall. So this is a kind of a transverse with posterior wall fracture. So when you take a special view of an obturator view, where you can see the complete profile of the posterior wall and broken iliopectineal with an intact obturator ring, and also in iliac view, you can see the exit of the ilioischial line. So now coming on to the T-shaped fracture, this is one of the fracture where it can be classified as a low bicolumnar also, where you can see there is a split in both the iliopectineal ilioischial line. There is a fracture extending down to the inferior ramus. The inferior extensions can be of variable. It can start from the pubic symphysis or in the middle of the obturator ring, or also at the ischial tuberosity. So depending upon the violence, the ring breaks at different levels, but the constant component is break in both the lines, and an intact part of an ilium is attached with the SI joint. So when you take an special view where you can see both the lines are broken, and sometimes in a transverse posterior wall, the line may be an intact. On a T-type fracture, the line is broken. So now we're coming on to the other part is an anterior column with posterior hemitransverse. Commonly, the anterior column, posterior hemitransverse, and both column fractures are most of them it will be a overlapping one. So it is an overlap. So there are some certain features which differentiates between both the things. We'll at the end of the class we'll form an algorithm on how to read all these X-rays. Here, an anterior column with posterior hemitransverse, the findings are both the lines are broken. The posterior column exists. The posterior column is a second fracture line which usually exists at very low level, and majority of time there is a portion of articular segment is attached to the ilium. This is one of the constant difference within bicolumnar fractures, where the weight bearing dome has been dissociated, and also the posterior column exists at different levels and taking a part of an articular surface, where it forms a classical spur sign where there is an inward displacement of the femoral head. So here you can see both the lines are broken and also a part of an articular fragment is attached to the ilium. So the findings in this X-ray are, you can take an operative view, the iliopectineal line is broken and also you can see the impaction of the dome. So the dome impaction where you can see, and also in an iliac view you can see the extension of the posterior column. The posterior column is always a secondary fracture line. It may be exits at very low level of ischial spine, or it may be intermediary around the greater sciatic nerve. That's why in anterior column with posterior hemitransit, most of the time that can be managed with an anterior based approach where you can place an posterior column screw through the anterior approach alone. Now when you come on to the last part of the classification is associated both column fractures. This is one of the severe form of an acetabular fractures. Both the columns are independently rotating on each other. So there's a dissociation of both the columns. And the other findings as per Letournel's description are there's an inward displacement of the posterior column. This is one of the constant fragment. And also there is a central or medialization of the femoral head. And there is a loss of articular continuity with an intact ilium. So this is one of the findings where you can see. So there is a loss of the articular surface along with the ilium. That is a characteristic of a spur sign. So when you take the Judet views, where you can see the classical spur sign and obturator view. The spur sign is a finding which commonly seen in an obturator view where there is dissociation of the weight bearing axis, and also you can see there is a lifting up of the roof along with the broken rim, and there is a constant the break in the obturator ring. So it causes the rotation of both the column fragments. And also in an iliac view where you can see the extension of the ilium fracture into the iliac profile, and also there is a break in the posterior column. So when both the lines are broken and when the spur sign is positive in an obturator view, it is one of the pathognomonic sign of a spur sign along with the broken obturator ring. So we have seen all the classifications, but we have to form an algorithm of so how to classify these fractures. So this slide is an empty now. In few minutes time, this slide is going to be one of the busiest slide of this presentation. So to summarize, when both the lines are intact, the iliopectineal and ilioischial lines are intact, when you take an obturator view, you can see the posterior wall fractures. So when there is an both the lines are intact, when you take an obturator view, when there is a break here, it is a posterior wall fracture. Now when you come out to the iliopectineal line is broken and an ilioischial line is intact, always it is a measure of an iliopectineal line is broken, it is an anterior column fractures. So and also when in the middle part of the anterior column involved, it is a part of an anterior wall fractures. So break in one line, it is an involvement of an anterior wall or an anterior column fractures. And when the iliopectineal line is intact, but only ilioischial line is broken, is always it is a measure of a posterior column fractures. And also sometimes an obturator view. So when you see a posterior wall fragment also, it is a posterior wall and column fractures. So no lines have been broken, the intactness, posterior wall, iliopectineal line is broken, it is an anterior wall and column fractures. When the ilioischial line is broken, when there is an posterior wall and column fractures. Now the other thing comes, when both the lines are broken, both the iliopectineal line and the ilioischial lines are broken, now we have 5 possibilities. So one thing is a transverse fracture, other thing is a transverse with posterior wall and a T-type fracture, the anterior column with posterior hemitransverse and a both column fracture. So we have 5 options. So to make difference between those, we have to look into the other findings also. When there is no fracture superior to the iliac wing, when it is at the level of the just above the joint level, so we have three options. So one thing is the transverse fracture and a transverse posterior wall, and also the T-type fractures. So the lines are at the level of is called the tectum fracture. So when it is at the level of tectum, when both the lines are broken, we have an option of a transverse fracture, the transverse posterior wall, and a T-type fracture. So further, when you come to the transverse fracture and transverse posterior wall, transverse fracture, we can see in obturator view that you can see the obturator ring is intact. So intactness of the obturator ring will give you a transverse fracture. When the intactness, the obturator ring with the posterior wall element and obturator view, we can diagnose as an posterior wall fractures. When the obturator ring is broken in obturator view, when both the lines are broken, it is called a T-type fracture. So this is how you differentiate a transverse posterior wall and a T-type fracture. So when the fracture line is extending up to the iliac wing, so at the level of a tectum, we have three options. When the fracture is extending up to the iliac wing, we have only two options. So one thing is you have to look onto the posterior column. When there is a low exit of the posterior column, it is called an anterior column with the posterior hemitransverse. And when high exit of the posterior column along with the spur sign, it has been diagnosed as both column fractures. And also in obturator view, you can see the classical spur sign where there is a dissociation of the weight bearing axis. Hence, to conclude, you can see this algorithm. So it is easy to diagnose an acetabular fractures based on all the lines. There will be a slight overlap of these fracture patterns in an anterior column with posterior hemitrans and also in both column fractures. However, when there is a doubt, so you always put it into the anterior posterior hemitrans, because when there is a doubt comes, most of the times an anterior based approach is sufficient to address the posterior column. When there is a real displacement of the posterior column, most often it becomes a variant of a both column fracture. It may be in a Y pattern or an X pattern where there is a more amount of comminution will be happening at the level of greater sciatic notch. So this is how we classify the acetabular fractures. Since to conclude, it is very essential to know about the pelvic osteology, which is the main foundation of our understanding of acetabular fractures. So it is very, very important to see all the radiographic landmarks, so which is a guiding light to diagnose all these complex fractures. So once you read about the landmarks like an anterior iliopectineal line, an ilioischial line, and an anterior wall, and a posterior wall, teardrop, and a roof of the acetabulum. So all these landmarks will give us a guiding light to diagnose these fractures. However, the CT scan expands the level of our understanding, and it is very, very useful for our preoperative planning in the form of a joint congruity and presence of an intra-articular loose fragments, the number and size of the fragments, associated femoral head fractures, and also the 3D subtractions are very, very useful in our understanding. Once the diagnosis has been made based on this classification, we can also plan our surgical approach for a good quality of reduction and an uneventful outcome. And also these classifications are very, very useful to keep our documentations. So in a year, in this hospital, we have seen around 70 to 100 acetabular fractures. We classify them and then we document them and preoperatively, and also we evaluate the postoperative quality of reduction, and also we do our outcomes and also the complications of the acetabular fractures. So thanks for your kind attention. Now I'm happy to have some questions.
Thank you very much, Ramesh. That was really very clear and concise, and I'm sure would have cleared out a lot of doubts among the residents. I'm sure they have some questions as well, so I'm sure please please feel free to ask them, and Ramesh will be happy to clarify your doubts.
Yeah, thank you very much, sir. While we are waiting for questions, sir, in one of your slide, you mentioned that for juxta articular transverse, the type of transverse fracture, sir, you need dual approach usually. Is that
Juxtatectal. Transtectal.
juxtatectal? Yeah.
The transverse fractures, what I always do is the degree of displacement of the femoral head. When the femoral head is displaced more anteriorly, I go for an anterior based approach, and then following a fixation of the anterior column, then we take the special views whether we got the reduction of the opposite column. So when the opposite column is reasonably reduced well, we pass a screw into the column from the anterior approach itself. Sometimes what I feel is this juxtatectal, sometimes when you close the thing in the posterior side, the anterior side opens.
It opens out, yeah.
So that is why we need little bit of a balanced approach so that we can get a reduction. We can pass an anterior column screw, then we can come back and fix the posterior column. So this commonly happens in a juxtatectal fractures. So what is your opinion, sir?
Yeah, absolutely. And also there are some transverse fractures where once you fix the posterior column, the anterior column is okay. And that's more in the lower fractures.
Yes, sir.
Okay, so then you don't need to always fix the anterior column, but wherever you can, it's good to put a screw across. But you have to make sure that the anterior column is reduced. And this is what happens if you compress it posteriorly, it tends to open out anteriorly. And so you need to put your finger in and check that the anterior column through the sciatic notch to make sure that the reduction is adequate.
Yes, sir.
The other important thing I think is the differentiation between the anterior column, posterior hemitransverse, and the T-type. So you mentioned anterior column, hemitransverse, and both columns. But the T-type, I think the most of the force is posterior.
Yes,
while
sir.
in the anterior column, posterior hemitransverse, the force is anterior. So
More anterior.
the head tends to displace with the anterior column, while in the T-type, it tends to displace with the posterior column.
Yes, sir.
And that may be one way of differentiating the two. Okay, so there's a question from...
Yes. Subhanshu has asked, sir, that most of the time patient having so much in pain while doing oblique view.
Okay.
Is the Judet view, sir. Then what to do?
So because if the patient is in pain, because we can tilt the gantry actually. When the patient is more painful and a part of a polytrauma, we don't do special views. So we take an
CT scan.
AP view and we take a CT scan. CT scan will give us all the special views and all the special things we have needed. In isolated acetabular fractures, when it doesn't have any much of pain, then we take all the special views.
Yeah, I think what happens is that although the CT will tell you everything because you can actually get the obturator and iliac views on the CT scan 3D reconstructions as well.
Yes, sir.
But in the OT, most people only have the X-rays and not the CT scans. So that is why it's still important to read the X-rays and understand the X-rays, because eventually when you're doing your surgery, you only have the X-rays. You don't have except those who have CT in their OR, that's different, but most of us don't have CT in the OR. So it's good to understand the X-rays properly so that you can understand your reduction and your fixation.
Yes.
Is there any time like the fracture which cannot be classified is happens as that, sir, which is not fit into this little Judet classification?
Sir, I have quite unusual fracture patterns.
Yeah.
The one thing is I have seen a classical transverse anterior wall fracture, sir. It's a very classical of a transverse anterior wall, and sometimes a part of an anterior infrailiac spine along with the iliac crest. There is an unusual variant of a posterior wall, and there is a lateral subluxation of the kind of a posterior superior subluxation of the hip. And I've seen a pure quadrilateral plate injury where there is only there is a minimal fracture in the anterior column, but a complete quadrilateral plate injury, the hip is dislocated into the pelvic cavity.
Yeah, it's interesting that there are lots of variations,
Variations.
and if you actually read Letournel's books, he's probably described almost all of them somewhere along the way. Okay, so although it's not there in the basic classification, the descriptions and what they fit into, like some of the both column fractures may not actually look like both column fractures, but the dome is separated from the axial skeleton, and that's the only way you can call it a both column fracture, because it doesn't exit out in the posterior column anywhere.
So the posterior bicolumn, both column variants are sometimes there will be a huge comminution at the level of greater sciatic notch, and sometimes it extends up to the classical
you can have,
IS.
the fracture can actually go up into the SI joint as well.
Exactly, sir. There's a kind of an like a kind of an sigma kind of an thing where there's the sacroiliac fragment will be a separate fragment.
Yeah. So those are all variations which you'll come across, unfortunately, meant to confuse you.
So, but
question about how
one
to
question is, yes. So Dr. Rupesh from Ganga, he has asked about how to conceal the patient and relative preoperatively and postoperatively. Is it different in different type of injuries according to classification? How to deal with complication in these injuries? So there are three questions in that.
Question number 1.
So how to conceal the patient and relative pre-op and post-operatively? Is it different in different type of injuries according to classification?
Not in different, it is essential. You have to understand that acetabular fracture is a high violent injury, and there's an intra-articular fracture. So we see most of our problems happens with the posterior wall fractures. So that is the commonest fracture, and most of our problems happen with the posterior wall fractures. So we have to explain about the complexity of the fracture and about the expected outcome of this fracture. So I always, depending upon the fracture pattern, I keep counseling the patient.
Yeah, I think you have to warn patients about AVN and secondary osteoarthritis in every case. Okay. Sciatic nerve injury, again, here documentation becomes very important, because sometimes you discover it post-op and there's been no documentation pre-op. Okay, so you don't know whether it's happened during surgery or it was there and no one recorded it. So these things are important to make sure that you're not missing these things. Similarly, Morel-Lavelle lesions. Okay, very often you may not notice it initially, and then you go to the OR and you find this huge Morel-Lavelle lesion, and the risk of infection goes up significantly.
So, sir, if there is Morel-Lavelle lesion, that treatment should be staged, sir. First Morel-Lavelle and later.
So I think it varies. I think it varies on the type of Morel-Lavelle lesion as well as the type of fracture. Because there's some, if it's dislocated, you can't leave it. If it's not coming closed, you have to reduce it. Otherwise, you're going to end up with other problems. But you have to also debride the Morel-Lavelle lesion adequately. Decide on whether you're going to close the wound or leave vac or things like that. So those are important decisions to be taken based on both the fracture and the lesion. Because not all Morel-Lavelle lesions are the same. Some are benign, some are pretty bad.
And another part of the question is how to deal with complication in these injuries.
If you have explained and well in advance, then we can manage. Because I have a complete documentation of all our complications. But most of our complications happens in the posterior wall fractures, even though we see it is a common one because of the arthritis and a kind of infections, and also transverse posterior wall fractures.
And
So
the
the
posterior column and posterior wall fracture. I
posterior,
think
yeah,
in
exactly.
Letournel series, that's one of the worst
Mm.
sort of prognostic value of these situations.
So we have also people are referred with an complicated like an infection. Infection, we always what we do is we do a debridement and then we do a vac application.
Yeah.
So we do a vac application. We have seen posterior wall fracture infection within a week, 3 weeks, and 3 months also. So within a week, I've seen a patient with debrided and then the implant was retained and then vac was applied and then the wound got contracted well. And probably at 3 months time, patient developed an complete collapse of the femoral head. So at that point of time, we just did an implant removal and a kind of an excision arthroplasty and cement spacer was applied. And after a speed of 6 to 8 weeks, with the control of all these inflammatory parameters, totally was done. And the delayed cases, what we do is we always debride, implant removal, and him on a traction, and then we put him on a cement spacer for some point of time.
Yeah.
Infection
Infection
is there?
So the one of the biggest problems is if you come back and you find that your reduction is not adequate.
Yes.
Okay, and there is that decision-making process where whether you think you need to go back and do something, or it is something which you are ready to accept and not go back in immediately. So I think that's a difficult decision at the best of times. So you have to then explain to the patient that this has happened. Why it's happened is because these are difficult fractures and sometimes your reduction may not be perfect. Or you might have to go posterior as well. You've done the initial thing anterior and then you have to go posterior. Or you've done the initial thing posterior and you realize in the post-op x-ray that you also need to do the anterior part.
Anterior.
So one last question, sir. That if there is a acetabular fracture and patient is stable, like elected and everything is okay, so we still need to wait for some time to take him to OT, or we straight like in next day we can take him to OT.
Yeah, it depends. If
So I think, yeah, so I think that with this, there's some issues about what medication they are on. So if they're on blood thinners, then you're better off waiting. Earlier on, there was a thing to wait if you were going anterior because they tended to bleed a lot. But I think today the teaching is going away from that. And we go in as, especially with the approaches where there's not so much bleeding like the anterior ilioinguinal approach or the infrapelvic approach, etc. So, but what do you say, Ramesh? What do you do?
so in an isolated stable acetabular fractures of an elementary one, there is no we can go
No
ahead.
need to wait, yeah.
Most of them, when they have a complex acetabular fracture, they'll have some kind of
Other
injuries also. So some kind of a knee injury at some moral level, or some we do CT scans kind of an hemoperitoneum. We generally wait for at least 3 days time.
Yeah. I think abdominal injuries can get missed, especially with pelvic more than acetabular. But yeah, you have to be very wary of that because, and the other thing is to have this good coordination between the general surgeons and the orthopedic surgeons, because you'll find them, they'll take it to the OR in night and they won't even tell you about it. And you could have put on the fixator at the same time or something like that. Okay. So thank you very much, Ramesh.
Sir, it's my pleasure. Thank you, sir.
Sure. Hopefully we'll catch you again sometime. So
yes, sir.
Okay. Bye. Bye, everybody.
Thanks.
Thank you. Thank you all.
Thank you very
Thanks,
much.
Janki.
Thank you very much, sir. It was great, sir. Great learning.